Hi, Jolly.
Hi, Sam. How are you?
I'm good, thank you.
I can see people are already coming in seriously,
Yes.
which is good.
Let me try to reach Murokora and see if Wasswa is supposed to join us here.
I'm trying to find Wasswa and the participants. We still have like 2-3 minutes to start. Dr. Sam,
Yes.
we have a presentation on Literature Digest, Research Literature Digest that will be presented by Brenda Carono. But at the end, she will need like 5 minutes. Huh?
Okay, she's called Brenda. Brenda
Carono.
Bruno.
The one who has MPDSR. Carono. Brenda Carono. Yes.
How are you, Brenda?
Just to factor that. It is a literature research digest. What they do is they produce a report on literature or research papers that have been published on the topic, and they compile them for the participants. So she'll just talk about what is in there, and then we'll share it out.
Okay.
The actual name of her presentation.
Richard, you'll be guiding us on you have the PowerPoint presentation?
Postpartum hemorrhage. Come
Richard,
again?
I missed you a bit. You'll be having the PowerPoint for the presenters, or they will be sharing on their own? The one they shared with you.
Those that are, yeah, I have them. Those that are able to share, that's fine. I'm not so sure.
Has Murokora shared with you?
Dr. Sam?
Yes.
I am not so sure of my internet today. I'm in the field. So don't try to share as much as possible. I'll try to come in as well.
Okay.
And when you're ready to start, just go ahead. We'll not have any remarks from my side.
Okay. So
whenever I deem fit, we can.
Let me first see if Dan Murokora, because the first presenter, I don't know whether he's good afternoon, colleagues. You're all welcome to this webinar. Maybe we give like about some 5 minutes for members to join in. Please bear with us.
So Dan is coming.
Now I don't know the semantics of these things. Are the people hearing us, or we are in our own place?
They are hearing you.
Hey.
They can see you.
Yes.
No, I wanted to ask Ononge for something. You know, I sent you the new presentation, which has in just one change, the ring on one of the slides. But I think it's okay in case he doesn't have it.
Okay. So Dan, we're waiting for Dan to join in.
You have given us our own chat room.
Richard Kajimu should do that next time.
So we normally do it, but because time had, we on time, We had to open it out, but usually we have our own before this. Yes, Dan? Mm.
And then Baifa, if you see Baifa.
So our participants, we really apologize for that delay. We're trying to have all our presenters in one room. Dr. Sam, Dan is having trouble joining.
Okay.
But we're trying to assist him to join.
Okay, we give him some 2 minutes.
Yes,
please.
Okay.
I would also like
to make an announcement.
Dr. Wasswa from Barra,
if you're in the participants
so that I
room,
can
please send me a
identify you and
message
move you to the
so that I
panelist.
can identify you and move you to the panelist section.
I think, Richard, we could begin by introducing the panelists. Just some brief remarks as we try to get the other panelists on board. So, colleagues, you're all welcome to this webinar, which is on postpartum hemorrhage. And we're delighted to have all of you senior colleagues in different capacities. First of all, thank you for sparing your time, despite knowing that you have tight schedule, and we appreciate you joining us. As colleagues, we can see we have reached about 120, but I know members are basically joining in knowing that this is a very, very important topic. PPH is the leading cause of maternal mortality. And if you looked at our statistics globally and even locally, nationally here, it is #1 killer. It kills very fast. And most times it takes us by surprise. So if you are not ready as a clinician or as a practitioner, this woman who came smiling with the expectation to go back home alive, unfortunately died in your hands. In the statistics, documented that within 2 hours, if you have a massive PPH, you are likely to end up with a maternal mortality. We have a list of panelists who are going to share with us the listed topics. And I just want to take this opportunity to introduce them briefly. The first person is going to talk on the overview of the magnitude of postpartum hemorrhage in Uganda. And that's none other than Dr. Dan Murokora. And we shall have Sister JaneFrancis Acam giving us the role of antenatal care in the prevention of postpartum hemorrhage. And we shall have Dr. Baifa Arwinyo, who will take us about preparedness of a facility to respond to a PPH. And indeed, we should be ready at all times for any eventuality if a woman starts bleeding. And we shall have Sister Hadijjah Nakatudde, who will take us on the role of heat-stable carbetocin in the prevention of PPH, emphasizing on the correct use. And we shall have our senior, Dr. Jolly Beyeza, taking us on the bundle approach in the management of PPH. And lastly, we shall have Q&A and then the closing remarks from our commissioner, Dr. Richard Mugisa. So they will present for maximum of 20 minutes each. At the end, we shall reserve the questions at the end. But after the questions, there's a presentation by Brenda Carono giving us some literature related with PPH, which we feel should be shared with the audience which is available here. So that is the outline of the presentation. Before we go to our first presenter, who is Dr. Murokora, we'd like to take this opportunity to pay our respect to one of our colleagues who was going to be with the Lord, Dr. Susan Anono, who just qualified from in Zambia University, Matas University. And unfortunately, we received the sad news that was passed on this morning. And we want to join the family and the colleagues in 1 minute of silence to pay our respect to Dr. Susan Anono. May our soul rest in eternal peace. So colleagues, there's a request for support. I believe it will be passed around. If you're able to, please let's support the family, because it has been the pain, and she has been in hospital for some time. We need to support each other. So Richard, how are we doing with the Dan Murokora? the first presenter. Dr. Richard.
Chair, I request that we start. We continue with the rest. Dan is still having issues joining. Yeah.
Okay. Together with me to co-facilitate this webinar is my senior, Dr. Salongo Wasswa, all the way from Barara, and he has mentored many, including myself. And I think he has great children now. Since I also have children, and is here joining co-facilitate with me. Let's take this opportunity to welcome JaneFrancis to take us through in 20 minutes what's the role of antenatal care in the prevention of PPH. JaneFrancis, over to you.
Yes, good afternoon, everyone. Hello.
Good afternoon, Sister JaneFrancis. We can hear you.
Can I request the chair to share the presentation?
Sam, are you able to share a presentation?
Thank you so much. Good afternoon, everyone. My name is JaneFrancis Acam, Principal Nursing Officer, Midwifery at Ministry of Health. I know they finished introducing me, and I can go ahead. So my task is to present the role of antenatal care in prevention of postpartum hemorrhage, and the presentation outline is introduction, objectives, antenatal services, focused antenatal care, goals of focused antenatal care, and then summary. Thank you. Antenatal services entail the holistic assessment of mother and fetus during pregnancy for the purpose of obtaining the best possible outcome for both the mother and the baby. It's also a series of appointments with a midwife or sometimes with a doctor in complicated cases, in case the mother is identified with a complication. Women and their families are equipped with appropriate information and advice for a healthy pregnancy, safe childbirth, and adequate postnatal recovery. And effective antenatal care depends on competent healthcare providers, functioning health systems, and referral services. We also look at adequate supplies and laboratory services. Why do we say competent healthcare providers? You find that in some facilities, some midwives provide services and some of them are not midwives. So objectives of antenatal care: to promote, protect, and maintain the health of a mother during pregnancy, to detect high-risk cases and give them special attention, to take decisions regarding timing and mode of delivery, to ensure the baby has a good start in life, and to teach the mother's element of child care. And lastly, to reduce maternal and infant mortality and morbidity, and to provide opportunities for health education of both parents with their children's well-being. So those are the objectives. What antenatal services do we offer? Screening for high-risk pregnancies, health promotion services, preventive services, curative and rehabilitation services, and then the natal care and the care at delivery. When we look at the screening of high-risk pregnancies, we look at factors that are associated with pregnancy. and this must be identified as early as possible. What do we say as early as possible? We look at first trimester. First trimester, and an appropriate referral is made. We look at the age of the mother. Below 18 years, these are mothers who are prone to obstructed labor. And if we don't attend to them well, the obstructed labor will make them get ruptured uterus, and then we end up with the PPH, or prolonged labor because we're not able to identify their conditions early, and then they get PPH. Even above 35 years, you find that these are mothers who are prone to PPH because they have produced many children, or they are having a pregnancy for the first time. The height and stature, we look at the height of 145 centimeters below, and then 5 feet high. And these are mothers who have abnormal pelvis. And when we leave them to labor, they may get complications and they get ruptured uterus, ending up in PPH. Booking weight, we know mothers below 45 and above 95 what it entails. Then the parity, first pregnancies, and then the grand multiparous. We have already talked about it. Birth interval, less than 2 years since birth. These are mothers who are prone to PPH because the placental insertion is very difficult, so they may end up getting APH, and then they get PPH. Multiple gestation, we all know that the uterus will be extra large, and contracting to stop the bleeding may be a problem, so they end up getting PPH. Abnormal iron presentations lead to rupture, and then the proteinuria leads to. So we look at previous bad histories, like previous cesarean section. If the mother is left again, not attended to, she may labor at home and gets a ruptured uterus. The myomectomies prevent contraction in third stage of labor, then the congenital anomalies. And then we look at the low birth weight babies, always comes with the precipitate labor. If a mother delivers low birth weight, always, these mothers get precipitate labor and they end up getting PPH. Then also big babies give tears to these mothers. The stillbirth, we know a macerated stillbirth, these mothers are prone to PPH. Mothers with APH, PPH, and manual removal. These are all candidates we screen during antenatal. Then mothers with gynecological history, fibroids, ovarian cysts, we look at them during booking. These are mothers that are prone to PPH. Pre-existing medical conditions like high blood pressure, cardiac disease, renal disease, diabetes, and sickle cell disease. These are all cases that are prone. Conditions developing during pregnancy like hepatitis B, HIV, AIDS, malaria in pregnancy, and severe anemia. And you find that these are cases that are prone to PPH during delivery. We also give health promotional services during antenatal to prevent PPH. The content would include educating the mother on the value of rest and recreation. You know, when the mother rests, she gets enough sleep, and you know, if she's ever active, she gets abruptio and leads to PPH. Discourage smoking and alcohol ingestion because when someone takes alcohol, she's bound to fall down and she gets abruptio, or get an accident and she gets abruptio. Then allaying anxiety, infant feeding, and contraception techniques. Contraception techniques to prevent another pregnancy less than 2 years. We also look at anxiety, which brings maybe prolonged labor that will lead to PPH. Nutrition education aimed at encouraging the mother to take an adequate diet based as far as possible on local available food, which are cheap. We normally encourage these mothers to take this food that is local available. For example, the green leaves of pumpkin, they are rich in iron, and we encourage mothers to take it. Education on improving personal hygiene and environmental sanitation to prevent them from getting infection that can lead them to ill health and also anemia in pregnancy, and then they get PPH during delivery. We also give preventive services like anti-malarials, malaria prophylaxis. As we know, malaria is one of the major causes of anemia in pregnancy. So, and when a mother is anemic and when she goes in labor, however little the blood she bleeds is called the PPH, and then we cannot able to save this mother. Prevention of malaria using IPTP, use of insecticide-treated nets to prevent malaria. We also offer hematinics like folic acid, ferrous sulfate, multivites, and good compliance of hematinics are shown to protect pregnant women from risk of anemia, especially in the developing countries where poor nutrition and helminthiasis are prevalent. So we need to prevent this anemia during antenatal such that during labor, the mother has enough blood. Next. We also offer curative and rehabilitative services, early diagnosis and prompt treatment of medical conditions that may arise in pregnancy. We know the conditions like malaria, HIV, high blood pressure. Emotional and social problems should be promptly diagnosed and managed, especially for the teenage mothers who say, I don't want this baby. They don't come for antenatal early. By the time they come to antenatal, they have very many complications. So we needed to help them come up from the community to antenatal. And when they come to antenatal, we offer them a very good social care, like counseling, telling them the benefits of antenatal care. Next. Next. So all these services we have listed down, we have to do them under focused antenatal care. A midwife is to offer focused antenatal care. This is an approach to antenatal care that emphasizes evidence-based, goal-directed actions, family-centered care, quality rather than quantity of visits. So when we take off goal-directed actions, when a mother comes, let's have specific directions, goals to achieve. What do we want to examine this mother on? What do we want to manage? It is not us only saying that she has come, you palpate the abdomen, and then she goes. Have we checked for a conjunctiva for anemia? Have you tested her urine? Have you taken her blood pressure? So then family-centered, is the husband involved? Are the caretakers also informed about what the pregnancy entails? And then at least a skilled birth attendant or a skilled service provider should be the one to attend for this antenatal. Next. Goals of focused antenatal care to promote maternal and newborn health and survival through early detection and treatment of problems and complications. Prevention of complications and disease, birth preparedness and complication readiness, and then health promotion. Goal number 1 talks of early detection and treatment of problems. We are looking at malaria. How do we detect malaria? Through history taking. And it is a detailed history. You have to ask the previous histories. You have to ask the current histories, the complaints. And then you go to do physical examination of the mother, look at fever and accompanying signs and symptoms. And the region where this mother lives, there are regions with high prevalence of malaria. Then you also manage complicated versus uncomplicated malaria, know how it is being managed. Then severe anemia, also we have to do physical examination, First of all, history taking, physical examination. We have to test for HB in antenatal, which we are really performing poorly, but we need to take it up. Preeclampsia and eclampsia by measuring of blood pressure and then protein in urine in case the blood pressure is high. HIV voluntary counseling and testing must be done to detect HIV that will give ill health to the mother. And then sexually transmitted infections, including syphilis. The syphilis testing, hepatitis B virus and hepatitis C virus. And then the rhesus incompatibility. Most of these mothers have that condition and will detect later. Goal number 2, prevention of diseases and complications. Using IPTP and use of insecticide-treated nets to prevent malaria. Tetanus toxoid to prevent maternal and neonatal tetanus. And then we have to give folic iron and folic acid and folate supplements to prevent anemia. Then we also emphasize on nutrition of the mother. And then goal number 3 is majorly birth preparedness and complication readiness. This is a process of planning for safe delivery and anticipating the actions needed in case of emergencies. Develop a birth plan, exact plan for the normal birth and possible complications. Arrangement made in advance by woman and family with the help of a skilled birth attendant. We need to have a husband involved in the birth plan. We normally make birth plans with the mothers and then we leave out to the husband. By the time the woman goes to tell the husband, the man runs away. And this birth plan should be reviewed, revised at every visit as need arise, because we want to reduce disorganization at the time of birth or in an emergency and ensure timely and appropriate care. And then the next one is to essential elements of individual birth plan that we should emphasize and discuss with the family. We look at the funds, personal savings. Does this mother have a personal saving, or the husband, or the family? Emergency funds. At least we encourage our mothers also to keep, even if it's 5,000 in her pocket, such that when in case of anything, she can call her border and take her. Community loan schemes, we encourage them to join in on those loan schemes such that they are able to get some money for help. Decision making, we all realize that our mothers depend on the decisions of their husbands. We want to encourage them also to make decisions as women. Who will make decisions, especially in an emergency? Is it the husband or the wife? So we need to talk to them about decision making. Family and community support. What is the role of a family and community? Is to care for a woman's family in her absence, in the woman's family absence and birth companion during labor. You know, sometimes our husbands go away and you find that the woman is left alone. So what is the support from the family? In case the man is not around, who will take care of the woman in case of an emergency? Then also we have to tell them to look for a donor, a blood donor in case of emergency. All pregnancies are emergencies. So we encourage them to do grouping and cross-matching in antenatal, and then they look for a donor who matches their group, and then look at the needed items for clean and safe delivery, but in case the mama kits are not in hospital. Goal number 4 is health education. Inform and educate the woman with health messages and counseling appropriate to individual needs, concerns, circumstances, the gestational age, most prevalent health issues. Support the woman in making decisions and solving actual or anticipated problems. Involve a partner and family in supporting adopting health practices. Always let's have the partners. That's why we are encouraging for male involvement. And the topics that we needed to address in order for us to achieve the good outcome after delivery: prevention of malaria by use of IPT and the ITN. Then also other methods of environment-free breeding sites for mosquitoes, personal protection, nutrition, care for common discomforts. Next, a use of potentially harmful substances to avoid, we need to tell them to avoid the herbs. Most of our mothers take local herbs that contain ergot, and then they get precipitate labor, they get cervical tears, which is a cause of PPH, they get ruptured uteri, then unperceived drugs, and then we also talk to them on hygiene to prevent them from getting infections that may lower their immunity and they get anemia. Rest and activity, we needed to tell them at least to have a rest every day, and also exercise, not only to sleep that they are pregnant. Importance of delivery by a skilled birth attendant. We need to encourage our mothers to deliver in a hospital, not by a TBA, not by a mother-in-law. At least they should deliver in a hospital where there is a skilled birth attendant. Then also we need to talk to them about sexual relations and safer sex. You know, if the sex is not safe, these mothers get abruptio and they end up with a PPH. Early and exclusive breastfeeding, especially for the young ones. You know, when you initiate a breastfeeding early, you prevent a PPH. And then prevention of tetanus and anemia, HIV prevention and care, prevention of other endemic diseases and deficiencies. Then child spacing, because we want to reduce the frequency of delivering within 2 years or less than 2 years. And then we tell them of danger signs during pregnancy. When should they report or when should they seek attention of a health worker? When they have vaginal bleeding or discharge, difficulty in breathing, fever, severe abdominal pain, severe headache or blurring of vision, swelling of the feet, convulsions, loss of consciousness, and labor pains before 37 weeks. And in summary, good antenatal care ensures that pregnant women remain healthy throughout pregnancy, that medical illnesses and pregnancy-related complications are detected early and treated promptly, early detection and referral of high-risk cases. And in the current approach to reduction of maternal mortality, a skilled birth attendant at childbirth is the most effective intervention. Thank you so much for listening.
Thank you. Yes, thank you, Sister Cham, for taking us through this comprehensive presentation, beyond even only PPH, but covering all the important aspects of antenatal. But if I could pick, in your conclusion, we need a healthy mother so that she can withstand any bleed at the time of delivery. And let's pick those who are at risk and refer them to another level. But let's also prepare them to basically know where to deliver from, knowing that if they are high risk, can you move to the next level? So thank you so much. Let's thank Sister. And if there was a way I can clap for you. If there are any questions for Sister Cham, please post them in the chat, or if you want to speak, you wait later and then you can ask questions at the time of Q&A, you'll ask questions. Let me take this opportunity to introduce the next presenter, who is not other than our own senior colleague. He is Dr. Dan Murokora. Dr. Dan Murokora is an obstetrician and a gynecologist with at least a 23-year experience and is currently working as a research health advisor at Ministry of Health. He is also our past president of AWOGO from 2009 to 2011, and he has worked here in Uganda, but also internationally in the field of maternal health and cervical cancer, and is currently supporting the implementation of the ARM chip, as well as the Reproductive Health Child Department of Ministry of Health. So let's welcome Dan Murokora to take us through overview of postpartum hemorrhage in Uganda and what is the burden of PPH. Murokora, over to you. Thank you.
Yeah, thank you very much, Chair. Good afternoon, everyone on this webinar. I'm going to focus more on the burden of PPH in this country so that it gives us a feel of what we are up against. So by way of introduction, we all know that postpartum hemorrhage is preventable, and it is a leading cause of mortality amongst women who are pregnant or have had childbirth. And there are risks that usually we can identify, and I think you heard from the previous presentation that these ones can be identified during the antenatal period. And many women who survive PPH, of course, develop lifelong complications that make their life generally unbearable. The burden is generally underestimated, and for a number of reasons. First of all, feasibility of accurate measurement in routine care, but also the tools that we have to measure PPH on a routine basis are generally inaccurate. Also, as you'll see later, the data that we usually capture is also incomplete. When we look at the global picture, overall, about 5% to 25% PPH is the burden globally. That is in terms of the women who experience postpartum hemorrhage. When we look at women who are delivering, prevalence per 100 women, for mild, for PPH that is 500 years or more, in Africa, we have the highest prevalence at 25.7%. But also, if you look at those ones who have severe PPH, we still have the highest in Africa at 5.1%, with Asia at the lowest at around 1.9%. It's a leading cause of mortality for all those deaths that are associated with delivery. And when you look at the case fatality rate,
Hello, Dan, have we lost you? Hello? Dan Murokora, have we lost you? Hello, Dan. Oh, sorry. As Dan joins back, maybe we could read some questions in the chat.
Thank you, Dan. Thank you, Dr. Ononge. There was a question about guidelines. Some guidelines and attitudes hinder antenatal care, like male factor, male partner.
Yeah, I hadn't finished presentation.
Oh, sorry.
Dan, we lost you a bit, so we're just jumping in.
Yes,
you,
sorry.
You go back to the leading cause, the previous slide.
Yes.
We lost, yeah,
Yes.
that one. So you are on the upper right, PPH is the leading cause, then we could not see you.
Oh, okay, sorry. So I was saying that up to 25% PPH is a leading cause of death worldwide, responsible up to about a quarter of all deaths associated with delivery. Then, of course, the global picture is 8% generally in developed countries. And then we have those case fatality rates. And I was saying that we have much higher case fatality rates in this country, as we will be showing you. And the risk of death from PPH is high for a woman who has been referred from another health facility. The next slide, I'm just going to pick up only on the risk that for a woman who is anemic, the risk for PPH is very high at 50%. And then when we come to maternal outcomes, PPH is affecting basically all age groups, but we see that overall we reach up to almost 48, 50% for women who are between 25 years, over 25 years. And then of course, when you look at maternal deaths, this is a report from last financial year. You can see that PPH contributed 80% and FH contributed 20%. So overall, this goes really to show you that we have a very big problem. The problem is preventable. And when we come to the PPH as a leading cause of death by health facility level, we see health center 2s and health center 3s at the tip. But generally, all levels of health facilities, PPH is the leading cause of maternal death. And I think also from the discussions we've been having in the past few weeks, the aspects of management of these patients that also make it a risk for women to die from PPH. So when we look at the trends over the quarters, we see that Kampala, if we start down here by region, Kampala has the highest case rate. And there's been an increase from 2020 to 2021. Nationally, we have an average of 2.4% case fatality rate. But we have seen that Ankole, Bugisu, and also Teso had major increases in case fatality rates. And therefore, this means that also these regions are experiencing higher numbers of postpartum hemorrhage. And of course, when you look at PPH as compared to other obstetric complications that are captured in the DHIS2, you can see the trends per quarter, but overall, if you compare with all the rest, still PPH is a major cause, it's a major obstetric complication. And not surprising from this, is that it's also a cause of death. And then, of course, it goes without saying that also the mortality trends are related, but I think we will skip this one. Let's go to antenatal care. And here, what we really want to show you is that overall, national, the proportion of women who are tested for antenatal using HB testing has been increasing over the last 2 years. But still, you can see that it's not acceptable for us to be testing only 1/5 of the women, because everyone coming through the antenatal clinic should receive at least 1 HB at the time of booking. And we can see that there are regional variations. We've seen improvements in Ankole, in Bukedi, Kampala, Kigezi, and so forth. But overall, we are testing only about 23% of women for antenatal. And for HB, but when you come down to see percentage of women who are tested in actual numbers, if you look down here, we have first ANC visit, we have about 1.8 million women, but we are only testing about 328,000 in 2020. And then we had 1.9 million women attend first antenatal, but only about 438 received a test. When you look at this in terms of the prevalence of anemia, so overall, we have a large proportion of women who actually are anemic. See, actually here almost 20%, Karamoja just over 20%, and then you have West Nile 13%, and all the others are in between 2 and 15%. This is a serious issue because, as you saw earlier, women who are anemic have almost a 50% chance of suffering postpartum hemorrhage. So looking at this, the burden is high. PPH is underestimated, and there's some other data, for example, which we could not get quickly. For example, proportion of women who died from PPH that have received blood transfusion or have an HB test. Those are other analytics that probably in the future we'll be able to share. So we must act now. And I think in terms of action, we'll be hearing more from the next presenters, how we should deal with this high burden postpartum hemorrhage. So Chair, over to you. Thank you very much for listening.
Thank you, Dr. Dan, for that elaborate presentation of the burden of PPH, but also of one of the comorbidities which can easily predispose a person to basically PPH. And I request you colleagues to keep your questions, or if you are in a hurry, put it in the chat. I would like to welcome those who have joined after I'd introduced. We want to move to the next presentation in the line, and I would like to ask Wasswa Salongo to introduce the next presenter, who is going to take us.
Thank you very much, Dr. Ononge.
Yes.
For taking us through those first parts, the first part of the webinar and presentations. We looked at antenatal care and the burden of disease. Now we want to talk about preparedness of the facility for postpartum hemorrhage. And to take us through this one is none other than Dr. Baifa. Dr. Baifa is now a seasoned gynecologist looking after part of the team that's looking after the whole of the northern region. And she's a consultant in Gulu Regional Referral Hospital. Dr. Baifa has a soft spot for mothers and their well-being and health, and she is very, very committed to their well-being. Ladies and gentlemen, let's welcome Dr. Baifa to take us through the issue of being prepared for postpartum hemorrhage at our health units. Dr. Baifa.
Thank you very much, Chair. Thank you very much, Dr. Wasswa, for that introduction. We are working in partnership with many other obstetricians and gynecologists in northern Uganda. I would like to request Richard to kindly share my presentation. Yes, my presentation, please.
Dr. Sam, are you able to?
Okay.
Baifa, are you seeing the presentation?
Yes, I can see, though it's not maximized.
Not maximized.
Okay. Okay.
Okay. Is it
Okay.
there?
Yes, it's there, though it's not full screen, but
Some,
I can still
you
start.
you need to download it first. I think you open it. You have opened it in the email.
Okay.
You need to download and then open it.
I've downloaded it. Let me see. How about now?
And now, first stop sharing and share your screen again.
Okay. Apologies for.
Okay, thank you very much,
Wonderful.
Dr. Sam and team. Thank you very much. My role is to talk about preparedness of the facility in response to postpartum hemorrhage. I'm Dr. Baifa once again. Next slide. Yes, I've looked at this part of the presentation at the different levels of the health system, to begin with the BMOC site and then also the CMOC site. So the first part is looking at a BMOC site, the health center 3 and the health center 2s that are conducting deliveries. How prepared should they be? I thought there is need to have presence of the critical cadres on site. In this case, at the BMOC site, we are talking about the midwives of all levels and plus other health personnel that will support the management of a patient with postpartum hemorrhage. And these critical cadres on site should be able to have the appropriate knowledge and skills of PPH risk identification right from the antenatal period. And then PPH prevention, how will they be able to prevent? And then also how they should be able to manage postpartum hemorrhage. So this knowledge should be availed to these critical cadres, either through in-service training, through webinar series and also, but they have to have the knowledge. And then there is need to offer the focused antenatal care services to our mothers, as JaneFrancis had mentioned earlier, hemoglobin estimation for all mothers during antenatal period, or if not all, at least for symptomatic mother, we need to have HB estimated and indicated in the card. And then imaging services, ultrasound, at least one ultrasound for every pregnant woman to be able to identify any possible risk factors such as placenta previa that stand as risk factors for postpartum hemorrhage in the long run. There's also need to be emergency prepared at a level 3 facility. We'll look at the PPH kit later on in the next slide, but they have to be emergency prepared at all times to manage any potential case of postpartum hemorrhage. And there is need to offer emergency care, in brackets ABC, and intervene before referral of any mother with a case of PPH. I've mentioned this because we receive mothers from BMOC sites with postpartum hemorrhage without any interventions being done or minimal interventions being done. So we expect that the BMOC facility is going to offer emergency care and get these patients out of danger before they actually referred to the CMOC sites for advanced intervention to prevent death. And then we have timely referral to CMOC sites. There is need to have a standby ambulance system in place for all BMOC sites, either on site, or we should have an emergency contact for an ambulance to pick up any potential a mother with postpartum hemorrhage to receive care at a higher facility if there is need for referral. And then we also need PPH protocols in place, updated protocols. So this is talking about the new guidelines should reach out to these BMOC sites. Next slide. Next slide, please. So the critical card at the BMOC site here is the midwife, who has to have the appropriate knowledge and the skill. And then looking at the CMOC sites, the health center for general hospitals and regional referrals, how prepared should we be? We need to have availability of the critical cadres in place. So we're looking at the midwife, the anesthetists, the lab personnel, especially for the health center force. We need the medical officer and the anesthetist to offer the CMOC function, especially cesarean section, and then also recommend blood transfusion for management of postpartum hemorrhage. So their absence at this level of care is very key. So they need to be available on station. And then the frontline midwives that happen to see PPH cases first should be able to offer emergency care before consultation is made. We do not want to find a case of PPH waiting for the specialist or the medical officer to review when the frontline health worker has not offered the emergency care that is required. The airway, breathing, circulation has not been secured for this patient. And then we're also looking at emergency preparedness even at this level. The PPH kit or the emergency tray should be available at the maternity of all facilities to prepare for any potential case of postpartum hemorrhage. We also need functional operating theaters in place, both physically, the structure has to be there and well equipped. And then we also need the critical cadres, the EMO anesthetists. We need the cleaners, we need the theater systems, the dobbies in place to ensure functionality of theaters in health center, first general hospitals, and the other levels of healthcare. Availability of sustainable blood for transfusion services for our patients. So this should be in place at CMOC sites. Why I mentioned sustainable, it should be sustained at all times. We need to have access to blood for transfusion. With functional fridges, I think the aspect of having a functional blood fridge is also key in this. And then lastly, they need to have updated protocols, even at these levels of care, to guide the critical cadres in the management of postpartum hemorrhage. This slide has a few words. It has basically emergency preparedness for PPH management and quality improvement. There's need to integrate QI in PPH preparedness. The 5S is very key. Where we take care of the cases of PPH, is the place well sorted? Have we sorted our equipment and supplies? Have we set them? Have we been able to standardize, our working area? And then is it shining? Is it enabling workflow in case an emergency or PPH comes in? This is very key. So that when I need a BP machine, I can easily access the BP machine if there is 5S in place. So this is something which we need to take home for all our maternity settings to respond to cases of PPH. Next slide. Okay, this slide shows us the PPH emergency box. The words are so small, but then it basically shows us what we need to have in the PPH kit. Maybe key to mention is we need to have wide bore cannulas in place, green, gray, orange, so on, okay, in place. And then there's need to have at least IV fluids, giving sets, blood giving sets, uterotonics in place. So when you look more into this PPH emergency box, these are items that we need in the emergency tray. And then this emergency tray should be replenished every morning. So we recommend that as midwives are handing over duty, we are also going to hand over the emergency tray to make sure what we used in the night is replaced in the day to wait for another potential case of postpartum hemorrhage and other obstetric emergencies. I'll not go deep into mentioning everything in this kit, but you will be availed with the kit. But key to mention, it should be replenished at all times. Emergency medical services for ambulance referrals. Having a standby ambulance or a functional ambulance line to call in case of emergency is key in preparedness for PPH management. So they need to have timely referrals. So frontline midwives should be able to identify a PPH case early, take care of the emergency issues around this mother, stabilize and refer in time. And then I mentioned issues of quality referrals. That means this midwife is going to call the facility they are referring to so that they can prepare to receive this case of PPH. So this will help with improving quality of care for this mother. So, and then the issues of having the midwife accompany the PPH case from the BMOC site to the CMOC site is very key. She should sit behind in the cabin, not with the driver, to ensure ongoing care en route to the referral facility. Next slide. Functional equipment and medical supplies. we need to have functional medical equipment in place to be prepared enough to manage a case of PPH. We need CBC machines in place. We need hemocues that are functional with cuvettes. We need functional autoclaves to sterilize equipment that we need to take care of PPH in case of tears and need for surgical intervention. And then there's also need to have, overhead lamps, emergency lighting to take care of such emergency cases when they appear in our facilities. And then the issues of supplies, they need to ensure that we have adequate stock of supplies, the ones with the emergency kit and other essential medical supplies in stock to take care of PPH case when it comes, especially uterotonics in place, IV cannulas in place, blood in place. And so this looks deep into ensuring that there is redistribution of supplies to high volume facilities that actually handle these cases. So to have this put in place, it needs a functional DHT that is able to oversee CMOC sites and BMOC sites and ensure that we do not have stockouts here and yet there is expiry the other side. So this equipment and supplies, stock management should be well done to ensure that we are prepared to manage any cases of PPH that comes in. Maybe lastly, one point that I didn't mention among the BMOC sites is there's need to have a functional VHT system to help with community case identification and timely referral from the community to the BMOC site to avoid late presentation to the facility. Thank you very much.
Thank you very much, Dr. Baifa, for taking us through being prepared for these mothers for postpartum hemorrhage. We note that the facility should be ready for any emergency, especially having identified that every mother is at risk for postpartum hemorrhage. So every mother who comes to be considered to be at risk, but of course there are those who are more at risk. The issue of the emergency tray has come out very strongly. Ladies and gentlemen, we need to have that emergency tray always ready and a way of calling people to help us during the teamwork. And the issue of the workplace, you must have the workplace ready to receive a mother with postpartum hemorrhage and handle that mother. And quality improvement deals with the going on improving all the time. Where are we? Where do we want to be? Okay. Our next presenter is none other than Madam Hadijjah Nakatudde. She's going to take us through one of the products that we use in management of postpartum hemorrhage. Hadijjah Nakatudde is a seasoned midwife. Not only is she that, but she's now a tutor at the International Institute of Health Sciences in Jinja. She has moved on to be an executive leader at the International Confederation of Midwives. Locally, she is also a member of the National Postpartum Hemorrhage Subcommittee and also a secretary to the Midwives Association of Uganda Eastern Branch. She is showing that she has a passion for mothers and to prevent postpartum hemorrhage. Madam Nakatudde is going to take us through the new products. This stable carbetocin for the prevention of postpartum hemorrhage. Madam Nakatudde.
Thank you so much, Dr. Salongo, and also thank you so much, Dr. Ononge. And I also take this opportunity to thank all the health workers, the frontline health workers who have managed to join in for this webinar. Yes, I have been introduced already, but I can still say my name is Nakatudde Hadijjah, and I am a very passionate midwife. I'm going to take you through heat stable carbetocin for the prevention of postpartum hemorrhage. And the previous discussants have been talking about PPH and the burden of PPH that we have in our country. Trust me, as we are out there talking about the mothers who are dying of PPH, amongst those mothers, we have the midwives themselves, we have the doctors, we have obstetricians, we have any health worker that you're thinking about. And that is why we are taking on the mantle as midwives to make sure that we prevent postpartum hemorrhage. Next slide, Dr. Ononge. So PPH is the leading direct cause of maternal deaths worldwide, just like the other presenters have said. And we realize that over 90% of deaths from PPH occur in low and lower middle income countries. And that is where Uganda is actually falling. So when you look at the graph that I have that is displayed, you realize that 27% is accounting for severe bleeding, and of which the 73% is for postpartum hemorrhage. So right now you can see how the burden is still there. 14% is for pregnancy-induced hypertension. And then, of course, we shall be sharing the slides and you see the other percentages. But to make an emphasis here, we are looking at the burden of PPH. Then also maternal morbidity due to PPH has a negative impact on women, their families, and the communities in low and middle income countries. And here, you look at the immediate health complications that are due to PPH, and under there we have hypovolemic shock, heart or renal failure, loss of fertility, and sepsis. And then under the long-term consequences, of course, we know that when a mother experiences severe comorbidity, it results in negative physical, psychological, financial, and social consequences. And this automatically impacts negatively on her family. Next slide, Dr. Ononge. So we want to see how we overcome the heat barrier to prevent PPH. We all know that the majority of deaths from PPH due to uterine atony could be prevented. But then the drug that we have is oxytocin. But this oxytocin, the current standard of care, the uterotonic that we are talking about, requires sustained cold chain transport and is supposed to be stored at 2 up to 8 degrees Celsius. And that means that we need a fridge in this space to maintain its effectiveness. But when you look at this graph, a study that was conducted in 64 countries show that it's only 22% of the health facilities across that have refrigerators. And of course, we get back to our country, Uganda, and we're asking ourselves, looking at the hard to reach areas that we have, looking at even the areas that are around Kampala, how many of these places do have refrigerators to maintain the potency of the oxytocin that we have? And also we realize that only 1 in 4 healthcare staff may be trained to maintain cold chain storage and distribution. So this poses a challenge in many low and middle income countries where access to sustained cold chain may not be readily available. And that is why new solutions are urgently needed to make sure that we have a drug that is heat stable and it will not require cold chain. So I go ahead and I discuss about heat stable carbetocin, which is the heat stable uterotonic in this space that we want to talk about. So heat stable carbetocin does not need to be transported or stored at 2 to 8 degrees Celsius. And this is really amazing. And then heat stable carbetocin is stable for 48 months when stored below 30 degrees Celsius, but point to note, it must not be frozen. Then heat stable carbetocin does not require refrigeration, reducing pressure on fragile cold chain transport and refrigerated storage infrastructure in LMNCs. So how is heat stable carbetocin different from oxytocin? Of course, we know that both of them are uterotonics in this space, but carbetocin is a long-acting synthetic analog of oxytocin that contracts the uterus. That is number 1. And then according to the WHO 2018 recommendations, which supports the use of heat stable carbetocin and prevention of PPH for all births in contexts where its cost is comparable to other effective uterotonics. So carbetocin is recommended in settings where oxytocin is unavailable or its quality cannot be guaranteed. And here we are so much focusing on the cold chain. So carbetocin has been added to the WHO model list of essential medicines. Then heat-stable carbetocin is approved for the prevention of uterine hemorrhage due to postpartum uterine atony following C-section and vaginal delivery. Dear health worker out there, don't forget that heat-stable carbetocin has also been added to the new essential maternal guidelines in Uganda. And if you haven't gotten a chance to look at it, you can access that on page 94 of the new clinical guidelines. Next slide, Dr. Ononge. So we want to look at these WHO recommendations. And of course, the first recommendation is the use of an effective uterotonic for the prevention of PPH during the third stage of labor is recommended for all births, and all births we are looking at cesarean section and vaginal births. So to effectively prevent PPH, only one of the following uterotonics should be used. We have oxytocin, but in this space, we want to so much focus on heat-stable carbetocin. Next slide, Dr. Ononge. So we are still looking at the WHO recommendations. One, the first recommendation says that if you want to prevent PPH, because we all know that PPH is preventable, the one, we need to use oxytocin, and that is 10 international units. It can be given IV or IM. And then the second recommendation is the use of heat-stable carbetocin. And heat-stable carbetocin is 100 micrograms. It can be given IM and IV. But here in the presentation, there are some things that we need to emphasize when it comes to that usage of heat-stable carbetocin. And then the last recommendation by WHO is like in settings where oxytocin is unavailable or its quality cannot be guaranteed, the use of other injectable uterotonics. In that space, we also have heat-stable carbetocin, or if appropriate, egometrin, all oxytocin and egometrin mixed dose combination, or oral misoprostol is recommended for the prevention of PPH. So this slide shows that heat-stable carbetocin is included in the WHO essential medicines list, and it comes as it comes under a uterotonic called carbetocin, and it is given as an injection, which is 100 micrograms per ml. Next slide, doctor. So we have so many uterotonic agents that are used in the prevention, but right now I want to so much focus on oxytocin versus carbetocin. When you look at oxytocin is the class of drug is oxytocin, and the example is oxytocin. So the mechanism of action of oxytocin is it binds at oxytocin receptors and stimulates myometric smooth muscle contractions. And then when we look at heat-stable carbetocin, it is a long-acting oxytocin analog. And the example there is carbetocin. But when you come to the mechanism of action, it is the same as oxytocin. But here is the difference. The duration when you administer heat-stable carbetocin is longer compared to when you administer oxytocin. Next slide, Dr. Ononge. So what is the clinical value of heat-stable carbetocin? Number one, we need to appreciate that heat-stable carbetocin does not require refrigeration and can be stored up to 48 months at a temperature of 30 degrees Celsius. And then also heat-stable carbetocin is reliable, long-acting, effective as a single dose, and easy to administer for the prevention of PPH. So according to the study that was done according to the network meta-analysis conducted in 2018, it showed that heat-stable carbetocin is the highest ranked single uterotonic agent for the prevention of a blood loss of less than 500 ml, of more than 500 ml. Then heat-stable carbetocin can equally reduce the use of additional uterotonics. And then lastly, heat-stable carbetocin and oxytocin have the most favorable side effect profiles among uterotonics to prevent PPH. So we want to compare and see. We want to compare heat-stable carbetocin and then oxytocin. In this slide, it shows that carbetocin has a longer half-life and duration of action than oxytocin due to an increased biological half-life in plasma and effect on the oxytocin receptor. And then also uterine contractions last approximately 4 times longer with carbetocin compared to oxytocin. So heat-stable carbetocin has a favorable safety profile. So according to the meta-analysis, heat-stable carbetocin and oxytocin have the most favorable side effect profiles among uterotonics to prevent PPH. And also we need to know that heat-stable carbetocin and oxytocin are the only, heat-stable carbetocin is the only uterotonic comparable to oxytocin across all side effects assessed in the network meta-analysis, including fever, nausea, shivering, and vomiting. So heat-stable carbetocin is long-acting, as I had already explained, and that makes it different from oxytocin. And we are saying that heat-stable carbetocin has rapid onset of action, that within 2 minutes of both giving heat-stable carbetocin, whether IV or IM, you're going to get an effect. It has a long half-life and prolonged duration of action, which is 60 minutes for a single IV injection, and then 119 minutes for an IM injection. Then also we need to know that heat-stable carbetocin can reduce the risk of uterine anatomy if used correctly and excessive bleeding following the single IM or IV injection. So oxytocin frequently requires slow bolus IV injections or infusion. But heat-stable carbetocin is reliable as a single standard dose. I need to emphasize this, that if you're going to use heat-stable carbetocin, it is 1 injection, one dose, 1 patient. You do not have to give 2 doses of heat-stable carbetocin to a patient. So potentially making it simple and convenient to administer. Next slide, Dr. Ononge. So in this slide, we are looking at the duration of effect for IM injection of heat-stable carbetocin versus oxytocin. You realize that when you give heat-stable carbetocin, it is going to take a duration of 119 minutes. But when you give an injection of oxytocin, it is going to take a duration of 30 minutes. Then what is the indication of heat-stable carbetocin? I need to emphasize this, that heat-stable carbetocin is approved for the prevention of uterine hemorrhage due to postpartum uterine atony. And heat-stable carbetocin must be administered only after the delivery of the infant. So what are some of the contraindications of heat-stable carbetocin? We must put this into consideration so that we use it correctly. Number 1, we must not use heat-stable carbetocin for augmentation or induction of labor. Number 2, during pregnancy and labor before the childbirth, because we said heat-stable carbetocin has a longer duration. So we must not give it during pregnancy. And then in women with serious cardiovascular disorders, in women with hepatic or renal disorders, in women with epilepsy, and in women with hypersensitivity to carbetocin, oxytocin, or any other of the excipients according to the composition. So those are some of the contraindications of heat-stable carbetocin. So the purpose of this webinar really is to bring out the most important things that we must look at as frontline health workers, especially the midwives out there, as you're going to use heat-stable carbetocin. The warnings are here. The use of heat-stable carbetocin in any stage before delivery of the infant is not appropriate because its uterotonic activity persists for several hours. And before you give heat-stable carbetocin, make sure that you first rule out the presence of another baby that is in multiple gestation before the administration. And then heat-stable carbetocin is contraindicated during pregnancy, including for the induction of labor. So important to note, never inject heat-stable carbetocin before the birth of the infant. So this is the packaging, and this is how heat-stable carbetocin looks like. It is carbetocin fairing. It is a commercial pack that contains 10 ampules per box. The pack has an orange background to differentiate with other uterotonic drugs. Then ampules, the ampule in the pack is 1 ml, and that 1 ml is containing 100 micrograms of carbetocin. And in addition, the solution contains the other things like methionine, succinic, and then sodium hydroxide. Then when it comes to administration, this is also important to know for our dear midwives out there, because we know that you are always the people who are always managing these mothers when they come for labor. Heat-stable carbetocin must be injected as soon as possible after the birth of the infant, and preferably before delivery of the placenta. So you can see in the diagram, birth of the infant, immediately after birth of the infant, and after ruling out gestational pregnancy, then you can give out heat-stable carbetocin. Then heat-stable carbetocin, Dr. Ononge, first get back to the, yes. Heat-stable carbetocin should only be administered by skilled health professionals, and then make sure that it is not a multiple gestation. I think I did explain that. Next slide. So when it comes to the administration of heat-stable carbetocin, the solution is in the ampule, is for use undiluted. This is important. We do not dilute heat-stable carbetocin for intravenous IV or IM injection. So you're supposed to use a 2 ml syringe for the injection. The ampule solution should not be diluted, because we know sometimes when you're going to give the oxytocin, you can dilute it. But for heat-stable carbetocin, important to note that the solution is not diluted before you give the injection. Then it is 1 ampule, 1 patient. This is important to note. And when you're administering, you make sure that in administration of heat-stable carbetocin, please, it is 1 patient, 1 dose. Then for IV injection, heat-stable carbetocin can be administered in both vaginal birth and cesarean section. So it is 1 ml administered slowly over 1 minute directly in the IV port. This is important to note, that please, if you're going to give heat-stable carbetocin for IV, it is administered slowly over 1 minute directly in the IV port. So do not inject heat-stable carbetocin into the intravenous fluid bag. Then for IM injection, heat-stable carbetocin is supposed to be injected as 1 ml, and 1 ml containing 100 micrograms. So it is supposed to be given IM, okay? Then next slide. So heat-stable carbetocin interactions. Heat-stable carbetocin can be administered for prevention. Remember, when I see questions are coming in and they are talking about, okay, so what happens if heat-stable carbetocin does not work? It means that now you have gone into the bit of management. But I'm emphasizing here that heat-stable carbetocin is for the prevention of PPH. So heat-stable carbetocin can be administered for prevention of PPH, even if oxytocin or other uterotonics have been given during labor. And then if bleeding occurs after administration of heat-stable carbetocin for prevention of PPH, then we are supposed to follow local protocols. Then tranexamic acid or uterotonics can be administered according to the local protocols. But that means that you have gone into the bit of management now. But now what we are emphasizing is, if you correctly use heat-stable carbetocin properly, it means that you are preventing PPH due to uterine atony the rightful way. Next slide. So how about the storage? We already said that heat-stable carbetocin remains stable for 48 months. And if stored below 30 degrees Celsius and 75% relative humidity. So data is available supporting higher temperature deviations during transport. That's why we said for heat-stable carbetocin, we should not get worried about the cold chain. So do not freeze heat-stable carbetocin. Ampules must be kept in the outer carton to protect the product from light during storage. And also make sure that you check the expiry date before you use the heat-stable carbetocin. And then when it comes to pharmacovigilance, midwives, doctor, nurse, patient, and relative should report any advanced drug reaction to heat-stable carbetocin to the local ministry, to the Ministry of Health number, or you can email this. That is the email for Ferring, because this is a product of Ferring Pharmaceuticals. Next slide, doctor. So in summary, heat-stable carbetocin is a WHO recommended uterotonic for prevention of PPH and is on WHO essential medicines list. I can assure you that for us here in Uganda, as I already told you, that heat-stable carbetocin is already in the new clinical guidelines used for the prevention of PPH, and that is in the management of third stage of labor. And also, Dr. Ononge, I think will add on this. We are working on the process of including heat-stable carbetocin on the EML of Uganda. And then also heat-stable carbetocin has a longer duration of uterine activity than oxytocin. Heat-stable carbetocin is beneficial for use in PPH prevention, but HSC should not be used during pregnancy or before birth of the baby. And also heat-stable carbetocin and oxytocin have the most favorable side effect profiles among uterotonics to prevent PPH. Heat-stable carbetocin is the only injectable uterotonic that can be stored in the approved storage condition at 30 degrees Celsius for 48 months. And lastly, only one dose, one patient, whether it is vaginal delivery or it is cesarean section. Please, heat-stable carbetocin is one dose, one patient. Thank you so much for listening.
Thank you very much for that presentation. I see there are quite a number of questions in the chat, but let Dr. Ononge present our next speaker, and then we shall go on. We shall then field all the questions. Thank you. Dr. Ononge. The next presenter is none other than our own Dr. Beyeza. Dr. Beyeza is a senior consultant and a seasoned obstetrician gynecologist in Uganda. She's an active member of the Association of Obstetrician Gynecologists and has a passion for mothers and their lives during pregnancy and labor. Dr. Beyeza is going to take us through something that is very important to us, how we are going to handle postpartum hemorrhage. Dr. Beyeza is going to take us through the postpartum hemorrhage bundle. Dr. Beyeza.
Thank you very much, Dr. Wasswa. And Dr. Ononge or Richard put my presentation. You forgot to say that I was also a past president of AOGU and the ED, the first executive director of AOGU. So maternal health is.
Sorry, Jolly, I'm trying to get your presentation. I was introducing you when my mic was muted. I didn't know. I was entering until.
Don't worry, put on. They all know me. Majority are my daughters and sons. Others are my colleagues, and the Wasswas are my senior colleagues. So it's okay. They all know me.
Yeah, Dr. Jolly, you needed to have something to say. If you don't love yourself, nobody loves you. You've got to say something good about yourself, not only other people.
Sorry, my computer is frozen. I don't know. Jolly, are you able to share the presentation?
No, isn't Kajimu there? I can't share because I don't have rights to share. Unless
just hold on a minute. I'm just.
Oh, you simply make me co-host.
Co-host.
Jolly, you're still able to share without being a co-host.
Are you serious? I didn't know that.
Yes. Look for a share button somewhere down.
So I downloaded it. Meanwhile, Wasswa will be answering some questions as we sort out technology.
Thank you very much. I thought we would just ask the presenters to answer the questions, and we can put in some additions as they answer the questions.
Now I don't see where to put in PowerPoint. Have I shared, guys?
Yes, go ahead.
I don't see the sharing. So I'm going to discuss something that FIGO has as very, very important to FIGO, PPH, and the Childbirth Committee, which I'm co-chair, and that is Management of PPH. And we are saying we would like to use a bundles approach. Bundles approach is not a buzzword, really, but I would say we are not I'm not presenting groundbreaking stuff, but it helps to create an approach which can be very helpful to us and to arrange our thoughts when we are managing this emergency. And where am I? Am I getting lost? And then the issue is that when you arrange your thoughts, when you put these bundles together, then you are able to. Is somebody doing the going up for me? I see things changing and I don't know. Hello?
Jolly, it is you alone with who is sharing.
I'm the one sharing.
Yes.
Hey.
So you scroll down.
I scroll down, and so what is happening now? Yeah, so this helps us to have can you do the screen for me, because I'm not finding my notes, and yet I have my notes. Please share for me. Sorry, people.
You can continue talking meanwhile.
Let me unshare and then you share as I continue talking.
Okay.
Okay, I've unshared, right?
Yes, you have stopped sharing.
Okay, then they can share for me as I talk through those 2 slides. I touched and things started running. Yeah, so the aim of the bundle approach is really to create a consistent, effective, and rapid emergency response to this life-threatening postpartum hemorrhage. Have you shared yet?
Not yet, I'm coming.
Yeah, I would say that the next slide they had seen, we'll run through it. It's a system kind of approach. And it shows that PPH should be managed within a complex system. You see, you have to have those different departments kind of shielding the emergency response in the middle, the teamwork, the communication, integration of the network, facilitaredness has already been talked about, respectful maternity care, but also the data and the quality money. Everything in the health system must work together to make sure that PPH is controlled. Next. Yeah, so the significance of PPH, I think, has been alluded to. We won't delay on this, but the issue is PPH is preventable, PPH is treatable, and that's why we are here, to make sure that even when it is still a burden internationally, we can do something about it. Next slide. Next slide, please. Yes, at a glance, when you look at that, and that is the card that we'll go looking at, the PPH emergency response, you see that this helps to ensure that all the important components of emergency response are used each time. And that is the bit of the response. So the emergency response, you must use the bundle approach. This today, my thing. Yeah, let's continue, please. I think emergency care using the bundle approach involves steps that can be done before you need advanced care. And this is the mainly today I would present the non-surgical approach. It is a key to preventing PPH early, and when successful, you will not need to refer, you will not need to do surgical issues. So what is a bundle? A bundle, if you may think bundles of things, bundles, you have different items in one item. So this emerged from the modern clinical practice. That means that you have to have a consistent way of doing things to get highest quality of care. It is also very useful when you see you are not the only one doing it. It's different teams elsewhere and everywhere in different units. When they use the bundle approach and they have these different supportive elements, it would be easier to remember, and it will also be easy to follow through each time you have that emergency. And of course, as you can see, you have the first response, then the refractory, then the supportive elements. So we'll go through this step by step. Let's say that when you get a trigger, the trigger is the diagnosis. And in our case, the diagnosis is the diagnosis of PPH. And we believe that all these elements, when done together, they give better outcomes, and it also helps to bring in a team approach. Yeah, next. Yeah, so there you can see that the PPH can be quite interesting. We should remember that the key contributors to PPH is failure to make a diagnosis, delay in early diagnosis, delay in the use of recommended interventions, and of course, the disorganized use of multiple interventions may make us fail to save a woman. The key issue is, do we have teams? Do we have a team approach? And that team behavior with a supportive system should be able to help. One key point of using a bundles approach is that it does not replace our clinical sound judgment. You have to do the right things. You do what is right for the patient. For example, if you need to do, you may need to do a bimanual compression, which you see there as a, what do you call it? As in the lower side at line 3, when you think this woman is powering and gushing blood, you may need to go ahead and do something which is ahead in order to save a life. So please, you have to use your clinical judgment. So the first bundle, you can see that, you click again, please. Yes, you can see that the first bundle after you've got a trigger, that is the diagnosis of PPH. There are those 4 critical things, and you must have them at your fingertips. Have I done A? Have I done B? Have I done C? Have I done D? Those 4, the massage, the IV fluids, the uterotonics, and tranexamic acid. Maybe I would say already that it doesn't have to be as they are listed there. You may change a few things as you are waiting for tranexamic acid. You are giving the fluids as you are waiting for the fluids, you are doing massage, the uterotonics, but the 4 have to be done in that first bundle. Next, please. So that is the contraction. I think we go through this one quickly, the IV fluids. Suffice to say that as we listened, we have different other drugs, alternative drugs like a uterotonic. What are you having? Don't run for carbetocin when you have, carbetocin is not for PPH prevention. For carboprost, when you have oxytocin, use what you have. Know what uterotonics you have. You know what fluids. You have ringers, normal saline. So as long as you put in fluids. Yeah, so supportive measures are helping us to make a diagnosis of PPH. The first one, the first bundle shows us that majority of PPH is due to uterine atony. So these are dealing mainly with uterine atony, and of course, tranexamic acid reduces the bleeding. So supportive measures, remember, they are for now looking at what else could be using causing PPH. So you look for the tears, you empty the bladder, and you also may look in the uterus to empty what is there. Next. Yeah, so those are the things. So refractory, you may have done all that and still the woman continues bleeding. So you go to the refractory interventions, and those are 3 as you can see them there. You need to compress, first of all, the uterus, the aorta, and the uterus you use bimanual compression, either external or internal. You may use uterine balloon tamponade, and this you should practice early on before the emergency. You know how we get a bit of being very stressed, and we start panicking when the condition when the emergency has occurred. So please, we practice earlier for this balloon tamponade, for aortic compression, for internal compression, all of those. And then the anti-shock garment. I think we are getting it popularized in Uganda. We used to have 1 or 2 in Augu those days, but I think now they are available in some clinics. Next. Yeah, of course, those are the issues. Those are the issues. And then next. Yeah, those that was not refractory, but the advanced care, part of the ongoing care, you need to give blood. You need to decide early on to transfer the patient to a higher level if you are in a lower level, or if you are in a tertiary. I saw somebody asking BMOC and CMOC, what are the differences? If you are in a CMOC facility, then you start thinking about other issues next. Yeah, and of course, the other issues may involve surgery. Next. We want to go through the things that they do at surgery, that is for the advanced care. But suffice to say that you must care for this woman as you are stopping the bleeding. Yes, you've stopped the bleeding, but monitoring. Many mothers die after the initial resuscitation has been done. So are we able to monitor this woman? The uterus has contracted. What happens when the uterotonic is stopped or the maneuvers have stopped? So we must monitor for uterine tone, the vital signs, estimating ongoing blood loss, and ensuring adequate fluid intake, and of course, blood transfusion if necessary, urine output. And we cannot emphasize the presence of a skilled attendant. Next. Yes, so this is a bit of additional best clinical practices. We had earlier on about prevention, PPH prevention, anemia prevention, malaria, all that is done at antenatal care. Then the first response, we need to see the early recognition of bleeding, because if we do not detect it, we know that PPH can kill within 2 hours. So these are the best practices that should be on our fingertips. We need to monitor mothers. If all mothers were monitored, that is the last one. If all mothers were monitored, things would be different. Even in the response to refractory, are we able to inform where we are referring? Are we informing the mothers? You know, these are the cross-cutting issues that that respective care should entail. And when we've done that, it's going to be helpful. Surgical management, of course, that is the last resort in PPH management, and that is some of the things that are done. Thank you very much.
Thank you so much, Dr. Jolly, my senior, for that exposition on the bundle approach for the care of PPH, and you have dissected it. I'm reminded with that when you have PPH, don't use a single bullet. If you have 4 guns, shoot them at once, such that you're able to arrest it in the first response. And evidence is coming that when you do that, then you might not move to the refractory PPH. We have one more presentation by Brenda. I don't know whether we could take some few questions first, but maybe let's allow Brenda Karono to provide some literature on for 5 minutes, and then you can go a Q&A. Brenda, are you able to provide some information?
Hopefully everyone is able to see my screen. I'll just take 5 minutes to run through all of this. So let me be sure to fit in that. I'm sorry, this is really huge. Okay, I'll go right ahead. Thank you everyone and the previous presenters, and most of what I was going to present has already been talked about, and I'll just go ahead to highlight what the research, the current research shows for postpartum hemorrhage, the role of ANC, facility preparedness, and emergency response in mitigating PPH. So how can we link the clinical manifestations, clinical outcomes to research? And what does that mean for implementers and programmatic people? So just in response to the four main topics that have been presented today, I'll go right ahead and just dive in with the role of antenatal care on mitigating PPH. So from the different roles that had been listed by one of the presenters, evidence has shown that for many mothers that do not attend ANC, the chances and risk of developing PPH at intrapartum care is high. So APH strongest predictors among study participants in the study with this link below, risk factors for PPH in Northern Province of Rwanda. And this study showed that mothers who developed APH had not attended ANC had a higher chance and a higher risk of developing primary PPH. So strengthening the component of ANC, the need for the 8 visits is paramount in improving maternal outcomes, as well as early capture of PPH in mothers receiving care. So from the implementation side, these findings call for more vigilance on the part of practitioners to attend to labor and birth, and during that process to identify women at risk, as well as having adequate preparation and birth plans in order to enable early interventions. And in another study by Focus, it mentioned practical approaches to preventing and managing PPH in resource-limited settings through various strategies, such as encouraging establishment of women groups coordinated by community health workers to enhance birth preparedness and encourage peer support. And this puts a highlight on the need for community maternal, neonatal, and child care in mitigating PPH. So moving on to the component of facility preparedness in responding to PPH. These 2 main studies are highlighted here, and this will be shared in a PowerPoint, as well as the extensive 12 studies that were pulled out for this particular webinar today. The title for this study was "We Do What We Can Do to Save a Woman," and these are health workers' perceptions of health facility readiness for management of PPH. This study explored perceptions of health workers regarding readiness of the facilities to provide PPH care. And it was reported that facilities that had low readiness for PPH management attributed them to issues of inconsistent essential supplies, fluctuating availability of blood for transfusion, and ineffective referral systems. The low readiness was reported to contribute to suboptimal clinical management and stressful situations. Additionally, this was superimposed by challenges in communication, collaboration, and leadership support. Therefore, supportive clinical leadership was reported as an enabler for provision of good care, poor facility readiness, as well as undermining undermined effectiveness of potential interventions for improving maternal health care. And this was in Tanzania, our neighbor here. And then one that stood out with actual interventions for practice is how to improve the quality of care for women with PPH at a particular hospital in Namibia, which was also a qualitative study. And the highlight from this was some of the outcomes included time taken to diagnose PPH and percentage of women who stabilized within 6 hours, as long as the quality of care given was good. It was also noted that sustainability of intervention requires well-structured training programs and strong health system leadership. So leadership, once again, comes out as a strong component for facility preparedness and readiness for change. And second last, we have the role of heat-stable carbetocin, and a lot has been spoken about the benefits, as well as why it is superior and how it can support reducing PPH in low to middle income countries like ours. So a study by I et al. Published in 2021 highlighted that the use of carbetocin in management and prevention of PPH is associated with reduced risk of vomiting. And this highlighted the need for taking care of other side effects that mothers get from pharmaceutical interventions during intrapartum care. And on the health economics side, it was noted, though, that there are some factors that could come in the way of implementing heat-stable carbetocin for PPH in low-resource settings. A rapid review was explored in resource-limited settings, and a number of these studies pulled up showed the effectiveness of heat stable carbetocin in tertiary hospital settings, but there was variation in the cost effectiveness. The review demonstrated a lack of evidence on the feasibility, acceptability, and health system considerations related to implementing heat stable carbetocin in resource constrained and lower maternity facilities. So there is need for more implementation research to inform design of heat stable carbetocin inclusive intervention packages and how to include them in the already existing interventions. And then lastly, about the bundle care approach to addressing PPH. Evidence comes from a study that was done by Joseph et al., published in 2020. There are some prerequisites needed to make for effectiveness of implementation of the PPH bundle. And these are highlighted from these papers below. The need to clearly define the burden of hemorrhage and align proposed change to institutional goals. And you realize we're still having a challenge of underreporting or under-documenting PPH, as well as misdiagnosis. The need to develop a strategy for open communication and involve key stakeholders across the entire continuum of care. Thirdly, providing effective training and iterative implementation of initiatives in the bundle, and then developing infrastructure support for integrating all the components of this bundle. And lastly, monitoring and evaluating process measures and health outcomes in implementing this bundle. So these were some of the, from the research, the proposed sequence for implementing the care bundle. And one, as you've seen, standardizing a hemorrhage protocol, defining a hemorrhage response team, and ensuring ongoing education and hemorrhage management, routine use of PPH risk assessment tool, and establishment of an easy method to communicate risk status to team members, employing QBO for all deliveries, developing and utilizing hemorrhage cards, and lastly, streamlining protocol adherence with an obstetric narrator. Thank you. This was a bit too fast, but we shall share these resources for your extensive reading after this webinar.
Thank you so much, Brenda, and your team for assembling that literature. Very, very important. Yesterday, when I was teaching some of the MMed students, I actually invited them for this webinar, and they were looking for research topics, and you have clearly highlighted what are the gaps for research, and I hope some of them have actually picked, because the majority of our audience are also students. So thank you so much, Brenda and your team, and this is great. There are some hands which are up, and then maybe some questions. The panelists should be able to attempt some of the questions, but we have about 4 hands. Let me see who was the...
Dr. Ononge, I have written down some of the questions. So after we get the hands, then we can put the questions to the presenters.
The presenters. Maybe let's see who was the...
I don't see any hands myself here.
There are hands. There are some hands. Let's start with Wes. Do you know Wes?
Hello?
Yes.
Are you getting me?
Yes, please. Can you go ahead?
This is Dr. Trinomjan from Mengo Hospital in the Department of Obs and Gynae. I would love to know more about why HIV positive pregnant mothers have a tendency to bleed a lot always after delivery, mostly those that always go for cesarean section. Thank you so much.
Thank you, Wes. Let's see also Tembo ask, and then we shall answer them all at once. Moses, Tembo. Moses, Tembo, can you unmute? Okay, maybe let's go to William Emaru.
Maybe they don't have the capacity to unmute.
They should be having, because Tembo Ways actually did it.
Okay.
Lily Achayo, are you able to unmute, or you're finding it difficult?
Very much.
Go ahead.
Yes, can you hear me? Yes. So this is Dr. Lily from Moroto in Karamoja. I work with Doctors South Africa. I had just one question in terms of, in regard to the presentation made by Dr. Ononge. You did present the figures regarding anemia diagnosis or testing during antenatal, and the figures show that we actually test less than 20% of mothers for anemia during pregnancy. And yet from the presentations also, it shows that that is one of the key precipitors of developing PPH. So my question is, what does Ministry of Health have in plans to scaling up anemia testing in lower facilities? We've seen some private facilities, especially those manned by partners, they're having hemocu machines, they're easy to use hemocu machines with hemocuvettes. So can Ministry of Health probably adapt this and scale this to lower facilities? Thank you.
Okay, I will ask Murokora to answer that question since he's close to the Minister of Health. Let's hear from Joan Namweso.
Thank you so much for the presentation. My question is about, we are saying that PPH is coming as a result of delayed referrals, but you may find and you reach at a region whereby all the centers, like maybe the center for which is in that region, they don't have an ambulance. As ministry, how are they going to help us? Like, you may reach in a region, it has so many health centers, which means center 2s, and then the center 3s, maybe one health center 4, which is regarded as a hospital. I may give my example of Ruuka, where I come from. That is the Chiunga, being the highest level where we are supposed to refer. But you may find that maybe a mother even moving from where we are coming from in deep in the health center 3, we are unable even to refer that mother to that level. Maybe because even the ambulance at that facility is not there. So how is the minister going to help in the ambulance system?
Okay, thank you, Joanne. We shall attempt on behalf of minister to say something. Okay. Maybe lastly, Dorothy Chene, and then Wasswa, you'll read the other questions and direct them to whom they fall to, then we answer at once. Before we take another.
Okay, thank you, Dr. Ononge. And thank you to all the presenters. Dr. Chene, Director Blood Bank. I'm so happy that blood has not come out as a real challenge or a real major issue as far as PPH is concerned and management. And I think maybe we need to educate our clinicians that blood is not the first choice in all cases, that we should try all the ways that have been put forward with Dr. Beyeza and company. So I think maybe if we train and if we mentor and if we give out guidelines this way, maybe people will know that even if you don't have blood in stock, you can.
Hello, Director. I think we have lost you.
Thank you so much.
Yeah, thank you, Director. And we want to appreciate the blood transfusion services that it has really supported the health facilities. And we're actually getting reports that the issue of shortage of blood is getting less and less. It is only maybe on our side, the ones requesting who sometimes delay in basically acquiring requesting for blood from the facilities. But we appreciate you so much and your team for what you're doing under blood transfusion. Don't hate us when we say there's no blood, because sometimes it's not there. Or the specific blood group.
We shall make sure that there's blood at least.
Oh, thank you so much. Dr. Wasswa, are you able to read those questions to the participants, then they can answer all at once?
Thank you very much.
Murokora will also answer the one of the ambulance. He has so many questions.
The first question also dealt with the issue of why HIV mothers, why is HIV a high risk condition for mothers to get postpartum hemorrhage?
I think I will answer
the first question.
I will answer that one.
Yeah.
Okay.
And then the other one was how does the safe sex predispose to postpartum hemorrhage? And what is safer sex or what is unsafe sex? That was to our presenter or about antenatal. And then the other question was in the guidelines, they say they want a male companion to escort the mother, male partner to escort the mother for antenatal clinic. Won't this reduce the mothers attending antenatal? because that's the requirement. There's going to be a requirement. And then the other question was, we have been supplementing mothers with hematinics, but mothers still come anemic. How do we handle this issue? Okay, then the other question was to Dr. Murokora. How do we improve hemoglobin estimation in all health units? I think Dr. Mugahi will talk about the issue of the HemaQ and the issue of availability of carbetocin in NMS to public institutions. To Dr. Nakatudde, question was, why don't we use stable carbetocin in multiple pregnancy? And how do we avoid giving it if a mother has an undiagnosed multiple pregnancy? I think that one should be taken by one of the obstetricians. What happens if heat stable carbetocin is used for augmentation? Because we said it should not be used for augmentation of labor nor induction of labor. Got that? Then the other question is, can we use oxytocin after giving heat stable carbetocin or vice versa? Can we use heat stable carbetocin after we've given oxytocin? And then to Dr. Beyeza, very difficult question to answer in a very short time. What are the steps in management of postpartum hemorrhage? And lastly, to Dr. Mugahi, the question was about the referral system. How can we improve the referral system? Thank you very much.
Thank you. We could begin with the Dr. Murokora. Dan, you can unmute and.
Yeah, so thank you very much for the question. So I think on the side of improving, I don't know if they meant improving coverage of ANC testing for HB testing for antenatal care.
Yes, Dr. Murokora, that was exactly it.
Yes, so this is an effort where from the project we're looking at buying equipment for HB testing, but I think these are things that all districts should prioritize so that if you can't do it from your RBF, then maybe you can put it in your annual budgets. But from the project, there is a process of procuring a number of HB testing equipment. And probably this may be in through after June of this year. The other question was on referral system. The ministry has bought a number of ambulances from various sources, both from our project and other global fund. These ones are managed through the center, but stationed at the region. We know that the coverage is still low, but also the Department of Emergency Services is still working out processes of improving the efficiency of their rollout. But it's advised that within each region, the regional referrals should work with the districts in working out a process of how to access their use. That is all I can say. But we will get the Commissioner Emergency Services to come to one of our weekly meetings to provide more information. Thank you.
Thank you. Thank you,
Dr. Murokora, they were asking, we have been supplementing, but mothers are still coming anemic. I think this is something more for clinical mothers with anemia before pregnancy.
I think we would need to handle each case properly because there could be other underlying factors. And I think from the presentation that Sister Acam made, she was clear about some of the risk factors for anemia, parasitic infections and so forth. So each client should be really investigated further beyond just the HP, so that we can clearly identify the cause of this anemia. If you go to Hemorrhage, for example, there's lots of issues around nutrition. Almost everyone is anemic amongst the pregnant women. They are delivering very frequently, like between babies, between pregnancies, the time is too short. Over to you, Chair. I think you were saying something.
Thank you. Yeah,
there was a question, Dr. Ononge, Dr. Murokora, that the new guidelines are talking of the male partner escorting the mother. Will this not reduce the number of mothers attending antenatal, especially the first antenatal visit?
Now, I don't think so, because we have male partners escorting, but their numbers are small. But if you have many, the only thing is that, which we've been thinking, is that there's nothing we do for these male partners. Because once they come, they are just either seated under a tree. If you can at least measure their blood pressure, also give them some health education, then they get to see the benefit of attending vesical escorting. I don't think it will actually reduce, unless if somebody has a new evidence.
Yeah, because if there are male services that can be provided, other testings for HIV, STIs, depression, that they are all sort of kept busy, they will stay.
Okay.
JaneFrancis, do you want to take on the question of what is the safer sex and how does the unsafe sex predispose postpartum hemorrhage?
Thank you so much, Chair. I'm wondering the person who asked the question, but safer sex, I know people know what safe sex is. But in regards to pregnancy, we realize that first of all, we need sex during pregnancy because we needed prostaglandins to stimulate labor, especially in a late pregnancy. And we know that the prostaglandins are contained within the semen of our males. So what I mean by safer sex during pregnancy, you know, when you're not pregnant in a local way that people play sex in different ways, in a rough way, but during pregnancy, we encourage the couples at least to adopt a position whereby the mother is not hurt. Because we know if the man plays vigorous sex can lead this mother in getting abruptio, placenta abruptio, that is early separation of the placenta, and we get APH that will lead us to PPH. So we need them to adopt the styles that can make the mother safe and the baby also safe. But defining safer sex, I know everybody knows what safe is, and that is it. Thank you. Then on the issue of male involvement, they have answered it. But I think we need the male. You look at our birth preparedness plan. We need to package some information. Even discussing a birth preparedness plan with the couple may encourage this man to come, because he understands really that it is his responsibility to get the mother, the woman, the things she needs. So, but I think that aspect is not embraced well, that we bring the two together and discuss about their pregnancy. Thank you.
Okay, thank you.
Thank you very much. The next questions were about heat-stable carbetocin. The first one was, will this heat-stable carbetocin be available from national medical stores to the public health units?
Yes.
Then the next one is
from July.
Okay. Are there some non-heat stable carbetocin preparations?
Yes. There is one which is available for private facilities. It's called Pabal.
Non-heat stable. Non-heat stable.
They are non-heat
stable. Is there non-heat stable carbetocin?
It is called Pabal.
Pabal.
Yes, it's available in the market and it's more expensive than the heat stable carbetocin.
Okay. Now the next question is, why do we not use heat stable carbetocin in multiple pregnancy?
Maybe to answer, just we say that you should ensure that the second baby is out. It is still used for multiple pregnancy. Ensure that the second baby is out. And how do we prevent that is by doing scans early enough so that we are able to identify those where we can easily trap the baby inside. Because if you give stable carbetocin when the baby is still inside, it has this long duration of action, which is for almost like 2 hours, and you suffocate the after coming baby.
Thank you very much.
Yes.
The next question is what happens, why should we not use stable carbetocin for induction of labor or for augmentation of labor?
The same reason of the long duration of action.
Okay, thank you very much. Then the last question on stable carbetocin is, can we use oxytocin after giving stable carbetocin and vice versa?
Yes, the moment you have noticed that the woman you remember Hadijjah's presentation was that give one vial for one patient, and if the patient continues bleeding, you now move to the treatment of PPH, which is the use of oxytocin. So you can move from stable carbetocin to oxytocin. Now you are treating PPH. However, if you had already given oxytocin and the bleeding is excessive, and then you want to give stable carbetocin, now you are not supposed to use stable carbetocin for treatment. You can't move from oxytocin to use stable carbetocin for treating a patient you have failed to manage with oxytocin. It is still only on prevention.
Probably you'd go to ergometrin now and probably some additional
and carboprost.
And let us note here that for every 10 vials of oxytocin, you're supposed to have 1 vial of ergometrin. But most treatments, you go and ask for ergometrin and they don't have it. The last question was to Dr. Beyeza. What are the steps of management of postpartum hemorrhage?
Oh, that's good. I will use 5 minutes, hopefully.
That is long. I use 2 minutes.
No, let's stop joking. You remember the very first card I put, the very first issue action you do. I'm going to put them in actions. The very first action you do is call for help. And when help comes, what do? You give them jobs to do. You take vital signs, pulse, BP, blah, blah. You take off blood for grouping, cross-matching, HB, blah, blah, blah. You put up fluids. Then now you start or initiate the first bundle. Because you've made a diagnosis of PPH, then you start the first bundle, which has 4 items. Remember them in your head. You remember the 5, the 4? You massage the uterus. You put, the person has helped you put a cannula, you put in IV fluids, you put in uterotonics. Don't start saying PPH, let me just first repeat whatever ergometrin or whatever. No, PPH, put up the fluid. Put in oxytocin, 20 to 40. If you don't have it, use other alternatives. The misoprostol, the what? I won't go through those, but give a uterotonic. And don't forget tranexamic acid. It helps in controlling the bleeding. So that is the second tier. Now, the supportive measures. Remember the 4 T's. It may not be atone, so look for tears. Empty the bladder. Empty the uterus. There could be some tissue. And look for clotting. That is the second phase. Bleeding may continue or it may stop, but again, it comes back. So you've gone to the refractory phase. So you have to do the refractory interventions. The other time you massage the uterus, now you have to compress it. Compress it, make sure that uterus contracts.
Okay.
Or you do aortic compression, then balloon tamponade and shock garment. Those 3 are in the refractory phase.
Okay.
Then also consider transfusion. That is where transfusion comes in. If you do not stop bleeding, you run for blood, you put it in as it comes out. So as Dr. Cheyune said, When do we need blood? Make sure that the uterus has stopped bleeding, then you can rush in blood. So blood is supportive at refractory phase. Consider referral if you are in a lower unit, or consider surgery. Those are supportive measures. I won't go into what to do in surgery. Aortic compression, you do it as you are waiting for a balloon tamponade, or you are waiting for a shock garment. We are waiting especially for balloon tamponade. Don't say I only do aortic compression as a supportive, as a refractory measure, because as you know, you are going to get tired and you release the aorta. That one is for just in the middle as you are waiting to do some other thing.
Okay.
Haven't I finished?
Yeah,
thank you very much, Doctor. Bundles means that you're not missing out any step in the management.
Yes.
The other thing is monitoring after spontaneous vaginal delivery and after cesarean section, you'll catch the postpartum hemorrhage. Okay. And lastly, when you're managing postpartum hemorrhage, remember to record what is being done. Dr. Ononge?
Yes, thank you. Thank you so much, Wasswa. I had one question. That was the HIV in relation to the PPH. The evidence from wide literature does not support that finding. Actually, there's a big study in South Africa where they followed out about 15,000 women who during the peripartum period, and 25% of them were HIV positive. And they did not find any difference between those who are HIV positive and HIV negative. That study is available. You can Google it out. But it's common to find that people report that HIV is an increased risk factor. And in small studies, it's actually documented it. And what has been shown in literature is that because of HIV in the beginning, people used to fear a lot HIV positive mothers. And there was a bit of negligence in terms of caring for these HIV mothers. And as a result, you find that these women are left unattended, and some of them have ended up experiencing PPH. But evidence does not support that HIV is a risk factor for PPH. I would like to take this opportunity to thank all of you. I'm not seeing the commissioner, whether he's around, but I'd like to appreciate all of you for standing up this time, especially our international audience participants. I would like to single out Moses Mugisha from Liberia, one of our own, and Rijal Shah from Geneva is attending this webinar. So this webinar is international. So colleagues, thank you so much for your time. As the closing remarks, PPH is a killer, and we need to do all what it requires for us to save our mothers. And the beautiful thing is that it is preventable. You can prevent it with available resources which we have. If we can enable that we prepare this woman during antenatal, manage the labor correctly, and use the right solutions, we should be able to reduce the 42% of hemorrhage to something which is less than 10% contributing maternal mortality. So thank you so much for all your questions, for your participation. In a special way, thanking the panelists for the well preparation and for the presentation. And let's continue to go and serve our community. And let's consider that every pregnant woman is at risk of PPH, and that's the only way we can save that woman. So thank you. May God bless you.
Andrew?
Thank you.
Yeah, thank you, Dr. Ononge, and thanks to the team. But importantly, thanks to the panelists who have committed a lot of time to ensure that they deliver this webinar in a very good and detailed manner. From the NASMEC side, we want to thank the PPH subcommittee for this webinar. Importantly to note, participants, that the PowerPoint and the recording will be shared on the emails that you used for registration. And also to note that these webinars happen every last Thursday of the month. So it means for the next month, we shall have a webinar, and it will be on neonatal care and kangaroo care. Thanks so much for committing this time, and we hope to have you again next month. Enjoy the rest of your evening and the rest of the week. Bye.
Doctor, confirm that there are CPD points for this webinar?
Yeah, this to notice, there are CPD points, by the way, for the webinar. And we are working or finalizing with professional body for the midwives. And so the CPDs will be across and cutting across all the cadres. So whenever you attend, be sure to receive your CPDs.
Thank you very much.
All right, bye.
Thank you, everyone. Bye.
Bye.
Bye.